All right. Hello, everybody. My name is Amalia Weber. I'm the program specialist here at Rochester Hills Public Library, and I'd like to welcome you to this evening's Smart Towns program, Advancements in Cardiovascular Care. Before we get started, I'd like to take care of a few housekeeping details. Firstly, tonight's program will be recorded and available to view about 1 week from tonight on our YouTube page and on the RHPL website shortly after. We ask the audience members please silence or turn off their cell phones before we begin in order to avoid any disturbances during the presentation. The Friends of the RHPL 8th Annual Wine, Wit, and Wisdom Fundraiser is taking place on Saturday, April 29th. The event takes place here at the library from 6 to 9:30 p.m. Audience members will attend 2 speaker presentations from a choice of 6. The evening also includes a buffet dinner, drinks, including wine, beer, and soft drinks, a silent auction, and a 50-50 raffle. Registration forms are available at the circulation desk, or you can visit rhpl.org/friends for more information. Our next program is Millennials and Money, Setting Yourself Up for Success, which will be an in-person event on Tuesday, March 28th at 7 p.m. You can sign up for that at calendar.rhpl.org. Tonight's program is presented in partnership with Smart Towns, a lifelong learning program for everyone in the community led by education organizations in Rochester, Rochester Hills, and Oakland Township, Michigan. Smart Towns offers lectures, presentations, and courses that introduce the participants to all aspects of the topic and are presented by experts in their respective fields of study. And now, without further ado, please welcome our presenter, Dr. Nishit Choksi.
Thank you and good evening. Thanks for coming today. It's beautiful weather out there. Spring is in the air. So thanks for taking time and coming here. I got some familiar faces there. So thanks again for taking time. The topic for today is advancements in cardiovascular care. There's so many new innovations that happen in cardiology. Every few months there's something very, very new. And it only furthers the patient's health, a person's health, not necessarily patient of course, and the person's health. And every few weeks, months, something that was thought to be impossible just a few months ago, a few years ago, becomes a possibility. And that generally happens in partnership with clinical doctors, research people, and above all, engineers. Because a lot of these devices, the idea may come from a physician, but it is then made into reality by the engineering folks. So any of the engineers around here, thank you very much. In fact, there's a whole new field of medicine that deals with engineering. Stanford has a very good program. The University of Michigan has a good program. So it is this symbiosis between different specialists that makes new things happen. And today I'm going to enumerate a few of the new things. Of course, if you have time, we'll talk about more. That has revolutionized care of patients with different disease processes. So I would first like to talk about a device called transaortic valve replacement. About 12 years ago, I was part of the team that did the very, very first aortic valve replacement in human beings in America. So there's a valve in the heart called the aortic valve, which is the main exit valve of the heart. It allows the blood to come out of the heart and to go to the rest of the body, be it the brain, the arms, the legs, the kidneys, etc. So typically as we mature, the aortic valve, which is located right there, becomes calcified and doesn't open too well. It narrows down. Sometimes it happens in younger population when they're born with a defective valve. So normally that valve has 3 leaflets, but some people are born with only 2 leaflets, and therefore the wear and tear of that valve happens by the 5th, 6th decades of life. But generally, the normal 3-leaflet aortic valve degenerates by 8th, 9th decade of life. Some earlier, some later, but generally in that time frame. Up until that time, the only way to fix this valve was to open your chest, take your old valve out, put a new valve in. It lasted for many, many years, decades I would say. It was a good treatment for its time because there was nothing else available. But that entailed opening the chest, anesthesia, bleeding, strokes, because you're cross-clamping the aorta, at least 7 to 8 days in the hospital, 6 to 8 weeks of recuperation. It'll be at least 3 months before you start feeling human. It's like a Mack truck has run over your chest, because you got to open the chest like that. So there's this guy from France who had devised this percutaneous valve, which is valve being placed without opening the chest from the groin up. So we were the first ones to do that, and FDA allowed us to do 10 cases in patients who had that problem, but who were on the doors of death, on the doorsteps of death. Nothing could have been done to them. Nothing could be offered to them because they were so sick. Their hearts were very weak, so they could not have replacement. They were old. They could have had lung problems, stroke problems, cancer problems. So they had many issues that did not make them a candidate for open heart surgery. So the first 2 cases went very well. The 3rd case, 4th case, and the 5th case, they checked out. They had celestial discharge. So again, FDA called us and wanted to know the details. Then they said, okay, we'll finish that 10 patients. The rest of the patients did well. And that was then. We've come a long way since then. We have to do a little cut down here in the artery, a little incision, and then put the catheter up. Today, we are able to replace the heart valve without any cutting, without any anesthesia. We just give some local anesthetic, just like some people may have had heart catheterization, the happy juice, and some local anesthetic in the leg area, and here we go. The valve is mounted inside a stent, and the stent is in a catheter. So you can see the blue catheter here. There's a plastic tube that goes up the groin. So once we go up with that catheter and we cross the valve, and we know the exact positioning on X-ray, we then inflate the balloon on which is mounted the stent, inside which is a valve. Once we do that, everything comes out except the valve. That's a metal ring, that's a stent. And immediately, the valve starts working. What happens to the old valve? The old valve gets plastered to the wall of the aorta. And this whole process, which used to take surgically 3 to 4 hours, and in the early years of doing this, 1.5 hours to 2 hours, now it takes about 45 minutes. And patient is up and about in the evening, and they go home the next day. They can lead a normal life. This is one of the few new devices that has not only improved the quality of life, but the quantity of life. We have decreased mortality, increased longevity. So the initial patients that we did were end-stage patients. Then they gave us approval to do high-risk patients. So patients who could have had surgery, but they were high risk. High risk for bleeding, high risk for strokes, they had blockages in the heart, and the carotid arteries up here, so they would have a high chance of stroke, or some other issues that would allow them to do surgery, but then some complication chances were much higher. In them, we were able to prove that this procedure was equivalent to surgical treatment. Then they allowed us to do intermediate risk patients, and lastly, about 4 years ago, data came out on low risk patients. So low risk would be defined as younger people, 50, 60 years of age, who had this problem, and they would have done very well with surgery, but then we one-to-one randomization did this, and it so turned out that this treatment was actually better than surgery. Complication rates were much lower. Patient's quality of life was better. Patients were up and about better, quicker. So this treatment has really taken hold and is here to stay. Before, this catheter that we insert from the groin were very large, the size of my thumb. Now it's the size of my pinky. So this catheter has become so small, and therefore we do not have to make any incisions in the groin to go up. Some people, unfortunately, have severe blockages in the leg arteries. So what do you do for them? So we go from the neck area, in the shoulder area, I should say. There's an artery called the subclavian artery or the axillary artery. We access that, and we're able to put this valve in there. There have been patients where we've used a carotid artery and went straight down from here and placed this valve. So there are what we call alternate access that we can use, but 95% of the patients we can go through the femoral artery or the artery in the groin. In the coming years, this is going to be even smaller and hence safer. Larger the catheter, more the complications. Not for the heart, but from the blood vessels. It can tear the blood vessel. It can make some plaque break up on its way up. So all those things were not uncommon in the early years of this procedure. But as the catheter got smaller, those kind of complications kind of went away. Also, early on, because the stent was, the thickness of the struts of the stent were big, and we were not very sure exactly where we would need to place the valve, there was a higher chance of the electrical wiring that is right here to get irritated. And therefore, these patients ended up with pacemakers. There was about 28% incidence of somebody needing pacemakers early on. But now it's down to about 5-6%. So remember, these are older folks who already have some electrical instability. There's some scarring of the electrical wiring in the heart. So just to go back a little bit, in the heart, you got the engine, which is the heart muscle. You got the valves. You got the heart arteries that are what we call the plumbing lines. And then you have an electrical wiring. And without the electrical wiring, the heart is not going to squeeze. And therefore, that incidence, because the electricity starts on the upper chamber of the heart, but there's a way station here called the AV node. And that's what would get irritated and swollen and sometimes scarred from this procedure. And therefore, electricity would not conduct from the upper to the lower chamber. And then they would need pacemakers. But now, the incidence that is extremely low. There are two kinds of valves. One is what we call balloon expandable valves, which you see here. And one is a self-expanding valve. And I won't go into much details, but the two are used for kind of a little bit different purposes. But the end result is that patient gets a nice new valve. Next, please. So here is what happens when you have surgery. The chest is opened up, and there are the retractors that has to open up the sternum. And then, of course, you open the heart, you put in a new valve, and then you close all these things, then you close the bones with stainless steel wires. Whereas with what we do, you go in from a blood vessel here, put it in, come out. We have an ability to take a suture in the artery without any cutting in the groin. And then patient leaves the room in about 45 minutes to an hour and sitting up in the chair in about 3 hours and walking in the hallway in about 6 to 8 hours. They're home next day majority of the time. Next, please. A lot of research has gone to that aortic valve replacement. The valve that they use is a cow valve. They're made from the cow's heart. And they usually last for a good 12 years. This is the same exact surgical valve, except the surgical valve is sewed in and this is put through a stent. Having said that, these valves don't last, they last about 12 years. Now the older valves that are put in surgically, the metal valves as we call them, they would last forever. But then you have to take blood thinners for the rest of your life. And not the modern day blood thinners where you don't have to do any blood testing and things like that. These are the old blood thinner called warfarin or coumadin. Some of you may be on that, or some of you may know people who are on that. Every 1 or 2 weeks you have to get a blood drawn to make sure that the coumadin levels are okay. So those would last forever, but then as somebody gets older and they have high risk for falling, and now you cannot stop the blood thinner because if you stop it, the valve will clot. And therefore, even the surgeons have moved away from using the metal valve and using the what we call a tissue valve or the cow valve. The advantage of that is 12, 14 years down the road, when that valve starts degenerating, you can put a valve inside a valve from the groin, and that will last you for another 12, 15 years. So technology has really come to fore. That we can put a valve, we can put valve in valve, we can put a valve in younger patients who have that bicuspid valve, which is a two-leaflet valve. And as I said, we can go from various accesses, from the groin, from the shoulder area, from the neck area, so there are different ways of going. I would then like to turn your attention to another valve called the mitral valve. So the first valve we talked about was this aortic valve, the main exit valve. The mitral valve is a valve that brings in fresh oxygenated blood from the lungs to the left upper chamber, goes through this parachute-like looking valve to the lower chamber, which is called the left ventricle, which is the main pumping chamber of the heart. As this chamber squeezes, it opens up this aortic valve and the blood comes out. So some people from childhood, from birth, have a condition called mitral valve prolapse. And majority of the times, 95-98% of the time, these patients will do well, sail through their life without any problems. But in a small percent of patients, this valve will start leaking backwards, meaning this valve is a one-way valve. The blood should only go from top to bottom. No blood should go from bottom to top. If it goes backwards, that condition is called mitral valve regurgitation. Or in layman's terms, we call it leaky valve. If it's mild, nothing happens. If it's moderate, usually nothing happens. But when a lot of blood is going backwards, you can see that, then this left upper chamber enlarges. One can get atrial fibrillation, which is an irregular heart rhythm that makes people short of breath, fatigued, tired, dizzy, lightheaded. And then a time comes when this cannot enlarge anymore. This just becomes a sac. And once this gets filled up, the blood goes back into the lungs. On one hand, blood is trying to come from the lungs into this chamber, but on the other hand, because of this backward flow, it's pushing the blood back into the lungs. And that condition is called congestive heart failure. The lung gets filled up with blood. Blood is water, majority. And patients get into heart failure. They can't breathe, they can't walk, they can't even lay flat in the bed. They have to sleep on 2-3 pillows like that. So that condition is a dangerous condition, and people can die from congestive heart failure. So again, over the years, this has been replaced or repaired surgically. The surgeon would go in, take this old valve out, and put a new valve in. Again, it could be a metal valve, it could be a tissue valve. Then the surgeons innovated some new techniques wherein they would kind of clean up this valve, shorten it, and put a little ring around the valve to bring it closer, and thereby reducing the backward flow. So if you can imagine a ring around this thing here, and bringing the valve leaflets closer, then the backward flow would be less. But again, that requires surgery. But it's a very good surgery. Patients have done well for years and years to come. But then there are patients whose heart is weak because of retrograde flow, or the heart is weak because they had heart attack, or the heart is weak because they got what we call cardiomyopathy, which is weakening of the heart due to viral infections. In this day and age, COVID, of course, but any virus can do that. Flu virus can do that. Coxsackie virus can do that. There are many viruses that can do that. When somebody gets a heart attack in this area, this heart will enlarge. Once the heart enlarges, there's mitral ring. There's a ring here in which is housed these two leaflets. They get drawn further apart. So they don't close. Normally when the valve closes, these two leaflets are opposed to each other very, very closely. But when they move apart, then they can't close fully, and the blood leaks backwards. So both for degenerative changes in this valve or functional, which is weak heart, heart attack, etc., one can fix this valve without surgery, and that procedure is called mitral valve clip or mitra clip. What we do is we go from the groin, from a vein in the groin. Unlike the TAVR, we go in the artery. Here we go in the vein. We cross over from the right upper chamber into the left upper chamber. Then we go across the valve and we deliver a clip. That clip is just like the clips that we used to use in olden era to hang clothes on the string. Same type of concept, just a little more expensive. and rust-proof. So once it brings these two leaflets together, this valve, which is like a fish mouth normally, becomes like a double barrel. And when this happens, the backward flow is almost halved, and in some patients almost negligible. And thereby the backward flow goes down, and people start breathing better, feeling better. And again, this is pretty much a 24 to 36 hour hospital admission. And once this is fixed, actually, the heart muscle function may improve. And when that improves, the heart failure improves. As the heart failure improves, patient can do activities, quality of life improves. So this is another area where we've been able to make tremendous change in people's quality of life and longevity. Longevity is something nobody can predict, right? And I could be gone tomorrow. But at least the quality of life you can improve, whatever life you've got left, 5 years, 10 years, 15 years. If one can improve the quality of life, then we've done our job. So this procedure is done strictly under ultrasound guidance. You put an ultrasound probe from the mouth into the food pipe. It's called a transesophageal echocardiogram. And sometimes we have to use X-ray, but by and large, on transesophageal echocardiogram, we can do this procedure. And that probe has an ultrasound chip at the tip, and you can see the valve from very close quarters, because the only thing between the ultrasound and the heart is a thin-walled food pipe. So we can see this structure very, very well. We can get 3D images of this valve also. So once again, in patients who cannot have mitral valve repair because of a variety of reasons, age, weak heart muscle, previous strokes, bad lungs, because when they have bad lungs, they're intubated, right? And they may not be able to get extubated. So in all these conditions where we cannot do surgery, then this is a very handy device that one can use to improve patients' symptoms of shortness of breath and congestive heart failure. So what the surgeons used to do is cut some of this tissue, tighten it up, and then around here, they would put a ring. The commonest ring used is called Carpentier's ring. It's a Frenchman who had devised that ring. It's kind of a C-shaped thing that kind of tightens the annulus, as we call it, that houses this valve and brings it closer together. Sometimes what happens with heart attacks is that, see, this valve is tethered to the heart muscle by these thinner muscles called chordae tendineae. So if somebody gets a heart attack here, then this tether is going to break away. And then one leaflet will not open or close. And that's how they get backward flow in heart failure. So there are a variety of reasons why this happens, but then it can be fixed. The only time when we cannot fix it is somebody's valve is leaking or regurgitating due to infection of the valve, what we call endocarditis in our language. The incidence of endocarditis has gone down significantly because we take appropriate measures during surgery, before surgery, etc. But if somebody does get endocarditis, then we cannot use these kind of techniques. Okay. Next, please. So again, here you can see that clip. We're trying to pass this clip down. And once we know that we have grasped it well, release the clip, and that's what the clip looks like. So it's like an inverted clip. Normally on the clothesline, you see this end holding the cord here. These two hands, they hold on to this valves and bring it close together. So this is the third valve. This is called the forgotten valve, the tricuspid valve. For years, we thought that this valve is not that important. The reason we thought it was not that important is because back in the 70s, the drug users, those people who use IV drugs, illicit drugs, I would say, they would get infection of this valve. And the only treatment in those days was to just take this valve out. And there was no replacement, not available. And these were young patients who did well. They died of other things, not of this, but then at least the infection got taken care of. But over the years, with the availability of ultrasound and transesophageal ultrasound and CAT scans and MRIs, etc., we realized that this is actually a very important valve. Because if this valve is not functional, and if there's what we call leakiness of the valve or retrograde flow of blood in this valve, your liver gets congested, you can get cirrhosis from this, you can get fluid buildup in the abdomen, we call that ascites, you can get swelling of the legs. There are a lot of patients who have a lot of swelling in the legs, and doctors are just giving them diuretics without doing any appropriate workup. Oh, your legs, you got fluid in the legs, but why do I have fluid in the legs? Nobody wants to answer that or even think of that. So there are many things that can cause fluid in the legs. Something from the heart, where this valve, so just to go back a little bit, the used blood from the legs, from the bowels, from the kidneys, etc., what we call venous blood, the dark blood, comes up the inferior vena cava. From there it goes into the right upper chamber. From there it goes into the right lower chamber. From here it's pumped out to the lungs, where they get oxygenated, get fresh oxygen. And then once it gets oxygen, it gets pumped into the left side of the heart that I showed you in the earlier slide. Now, if this valve is leaking, meaning blood is going backwards instead of just in this direction, what's going to happen? Blood is trying to come this way, but the valve is not competent, so the blood is trying to go back that way, because when this chamber of the heart squeezes, the blood will go and take the path of least resistance. And the path of least resistance would be here, because the valve is not closing well. It's opening fine, but it's not closing well. And therefore, the blood goes backwards, as the pressure increases backwards. So your liver is right here. So your liver gets congested. And then further down, the blood kind of stays in the legs, and people can't walk. Their legs are like elephants. There are other local conditions in the legs that can make someone's legs edematous or swollen. And the concept is similar. Just like we have valves in the heart, there are valves in the veins of the legs. And they can also become incompetent. So normally as the used blood comes up and goes to the lungs, if it tries to come back down by gravity, when you're standing, gravity is working. But then at that time the valve will be closed, so blood cannot come down through that same vein. But some people's valves are not working well, sometimes from trauma, sometimes from procedures done in the pelvis, surgical procedure that traumatizes the veins here, and therefore, by gravity, the blood goes back down. So one may not have any heart problem, they may just have incompetent valves in the veins of the legs, and that can be also taken care of in about 70–80% of the patients. But then this valve nobody thinks about. But when we do a regular heart ultrasound through the chest, we call it echocardiogram, some of you may have had it, this valve is not particularly very well seen. And if you are suspecting leaky valve here, then the best thing is to do a transesophageal echocardiogram, and you can see the regurgitant jet very well. So there are many times when we've done regular ultrasound echo, and we think it's just moderate, but when we put that probe down, it is actually severe. And therefore this has to be fixed. Again, just like all the other valves, initial way of fixing it was surgery, and now we can fix it without surgery. So see these clips that I put in here? So we bring at least 2 of the 3 leaflets here. If you can bring 2 of the leaflets close to each other, then the orifice is narrowed down, and therefore the backward jet is decreased, and hence patient will have less what we call tricuspid valve regurgitation, and therefore less congestion of the liver, less leg edema, less ascites, which is fluid buildup in the belly, and things like that. Now even here, trials are ongoing in certain hospitals in the country where one would be able to replace this valve. There's actually an artificial valve right here without surgery. And that probably in the next 2 to 3 years that will become reality. It's that close. Now, currently what we are also doing is, if we cannot replace this valve and we are not able to grasp these 2 leaflets and make it come together with the clip, then we put a valve through the groin right at the junction of the inferior vena cava and this right upper chamber. So even though the blood may come backwards from the right lower chamber to the right upper chamber, it won't go down, regurgitate down, because there's another valve here. So that is another thing that is relatively new that we are able to do, and thereby decreasing liver complications of this problem, leg complications of this problem, and things of that nature. There's another valve replacement of the tricuspid valve. It's currently in research, but I think it'll be available in a very short course of time. So again, this was the mitral valve that I talked to you about, the tricuspid valve, we're talking about the aortic valve. Next, please. Now moving away from the heart a little bit, and this is very important because during COVID times, you may have heard a lot of patients get blood clots in the lungs. We call it pulmonary embolism. It can happen even for non-COVID patients, but most of these patients have some clotting disorder. They're thrombogenic, they easily form blood clots. Most of the clots that go to the lungs, they go from the clots in the veins of the legs. So people have had a long car ride from Florida, they drive to Michigan, they're sitting there for 10 hours, blood pools in the legs, blood clot happens. And the blood clot can break loose, go upstream from there, all the way through the heart, through the right side of the heart into the lungs. And this can be catastrophic. People can die from this. During COVID times, this became an acute problem because COVID itself was making the blood, quote unquote, thicker, thrombogenic. So you may have heard of your friends, neighbors having a stroke from COVID, having heart attacks from COVID, having kidney failure from COVID, having blood clots in the leg from COVID, having blood clots here. So that's what COVID had done to the human race. Now, how do we treat this? Because there are three ways of treating it. One is just give some blood thinners that we used to do for decades. That blood thinner is called heparin. And then after 2-3 days of heparin, you put them on oral blood thinners. But it's a blood thinner, it doesn't dissolve the clot. It may, the clot may dissolve partially due to body's own chemicals, but that heparin itself doesn't dissolve the clot. That's one thing we have to remember. Then came clot busting medications. There was medicine called TPA or tenecteplase. There was another one, which we used it in the past. Just like heart attack patients back in the 80s, we used to use clot busting medications, streptokinase, urokinase, TPA, tenecteplase, etc. But then we realized that these are clot busting medications, they have complications. Bleeding is number one. People bleed in their brains actually with that medication, they can die. I very vividly remember it was 1985, 84, 85, and Beaumont Hospital, where I trained, was one of the few hospitals in the state doing angioplasty. Actually, we were the first ones to do angioplasty in a heart attack in the country. In fact, New York Times had headline, first page article that cowboys from Michigan are putting balloons in patients' heart arteries during the sickest situation. So this young lady was having a heart attack, was flown from Port Huron for further management here because she was still having chest pain, and obviously the clot busting medicine does not dissolve the clot. She landed here, we were wheeling her to the cath lab, and suddenly she said, I'm having a severe headache. And the next thing we knew, she was unresponsive. She bled from that in the brain. We could not save her. She just... So that is stuck right here. And that is not an uncommon problem with clot busting medication, because you have to use a large amount of this clot busting medication. So same thing here, treatment started with heparin, which is a regular blood thinner, then they started giving clot busting medications, and with that obviously bleeding complications improved significantly. The other thing that we realized is these clots have been sitting here for a few days in the leg, and then it breaks loose and goes upstream. Now so clot is made out of fibrin, but within a few days, that fibrin becomes collagen, and you cannot dissolve collagen with clot busting medication. So when the clot goes up a few days later, yes, you'll dissolve some clots, but the collagen part of it you will not dissolve. So there'll be a lot of clots that will stay in the pulmonary artery, and that has long-term ramifications, because if the clots are in the lung arteries here, this is your right lung, then over a period of time, the blood that is being pushed from the right side of the heart into the lungs will meet with a lot of resistance. So the pressures here will go up, and we call that pulmonary hypertension. And people with pulmonary hypertension have very high morbidity and mortality. So clot dissolving medication served its purpose because there was no other treatment available. But then those people decided, okay, let's do this. Rather than giving clot busting medications through the IV and giving a large dose of that, let's just put some catheters right into this area and give clot busting medications, much lower dose, 10 milligrams instead of 100 milligrams, and see whether that helps. So it did help. But then patient would hemorrhage inside the lung itself, because remember, that portion of the lung is getting necrosed because there's no blood flow. Just like when the heart artery chokes up, get heart attack, what happens in heart attack? The muscle necrosis, it dies. So people were coughing up blood. And therefore we thought, well, this is not a good idea either. Why don't we just go in and suck out these clots? And about the time COVID came, fortunately, a new device came out called FlowTriever. There's another one called ClotTriever. It's made by a company called Inari. It's a large bore catheter that we put up inside from the groin up through the heart into the artery, and then it has a suction. And that suction can suck 150 cc's per second. And it sucks out not only the fresh clot, but also the old clot. See this? This looks like a python here. But this is actually the shape of one of the arteries in there. That's the shape it took. This is what we take out. And within minutes of this, patient's symptoms get better. So what are the symptoms? Patient gets chest pain. Patient gets very short of breath because there's not much oxygen going in. And there's something called pulmonary artery pressure that goes up, called pulmonary hypertension. As soon as these clots are removed, the pulmonary pressures go down, the oxygen goes up, and patient starts feeling better right away. The chest pain also decreases significantly. So this is a very good example of all these clots that we remove. And then the blood pressure improves. Why does the blood pressure improve? If there's no blood going to the lungs, and remember, the purified blood from the lungs goes back to the heart, the left side of the heart. But if the blood is just not moving forward, then obviously the left side of the heart is not going to get much blood. So there's no oomph available. So blood pressure goes down. And as a result, patient can die. So once we clear up these clots, the blood flows like gangbusters, and then the blood goes to the left side of the heart very easily, and then blood pressure will increase as a result of that. Next slide, please. There's another example of that. You can see that there's some blood going into the upper part of the lung, but no blood going in the middle and the lower part of the lung. Very little. You can see all these oligemic areas are these areas where the dark is the blood. Okay, these are arteries, the arteries in the lungs, and the dark is the blood inside the artery. So these areas you are seeing there's nothing much going on, but there are clots in there. So we took out these large snakes-like clots. Can you see that? Can everybody see that? We took it out from there, and now the whole lung lights up like a Christmas tree. There's blood going to the upper part of the left lung, middle part of the left lung, lower part of the left lung, and voila, patient does very well. They can go home next day on some oral blood thinners. We do keep them on blood thinners only because we don't want any new clots to form and go upstream. And they stay on blood thinners for about 6 months. Similar thing can happen in the legs. Some people come suddenly with leg swelling. These are patients, as I said, who travel for long distances. They don't walk at all during their 10-hour car drive or long plane ride. This can also happen in patients who have cancer. Blood kind of, quote-unquote, thickens. They become thrombogenic. Prostate cancer is one of them. And clots form in the leg swells up, a lot of pain. So we go in from one of the veins in the leg from behind here, go all the way up, suck out the clots, and again within a short period of time, the leg shrinks, the blood starts flowing back up again. So these are some of the latest things that we have. And and we do a lot of these at our Ascension Hospital, right across, very close to you guys. We had a school teacher who was on hormonal treatment and doing well, active lady. She was in school, she's walking from class to class, very active lady. Suddenly her leg swelled up. She thought maybe she may have traumatized her leg, she didn't pay much attention. Next day, she was short of breath. So the clot went up. So she came to the emergency room. They did a CAT scan. You can get all these pictures with just a CAT scan. And lo and behold, she had clot in the lungs. So we told her that we can do this for her and relieve her of all these clots and improve her symptoms. Oh, now I'm feeling better with the blood thinner. I'm feeling better. I said, you're feeling better because you're laying in the bed for the last 18 hours. When you're not doing any activity, you're not short of breath. But let's walk around the hallway. So I walked around the hallway and she couldn't walk 20 steps. She was short of breath. Then she agreed, let's go and get it done. And then we got it done, and within minutes of sucking out the clots, she started feeling a whole lot better. She said, maybe I was not feeling good. I thought I was feeling okay, but now I'm feeling better, so I was not feeling that great, obviously. So again, these kind of innovations in cardiovascular medicine really improved the outcomes for the patients. Now this is a very large catheter. This is even a little bigger than my thumb. But the newer ones that are going to come out are going to be much smaller than this catheter and have the same capability of sucking out the clots. So you can see how big this clot is.
How big is that?
This would be about, it says here measurement, this is a 10 cc, this is a scalpel, so this is about 8 centimeters, 8 to 10 centimeters. Yeah, about year long. So, sometimes, I mean, this is just a sampler that we've shown. There are like multitudes of this linear clots that we removed because the whole area was clotted. So we made multiple passes and we were able to take the clots out. Next slide, please. There's another patient. She presented to the emergency room, massive, so this is a CAT scan. You can see clots in the lungs here. And she came to the ER, discharged a day after this clot removal. And this is one of the earlier ones that was done at Pensacola Hospital, Sacred Heart. And you can see the number of clots removed, all this. Some of these are older, some of these are fresh clots. And patients started feeling a whole lot better. Now, if you don't do these things, as I said, pulmonary pressures go up and then there's a lifetime of misery. So just imagine a 50-year-old person has this clot. Another 20, 30 years, they would not be breathing well, the pressure in the lungs would be high, they would have leg swelling, constant leg swelling. And once your leg swelling, the skin breaks, you're oozing from the skin. Once the skin breaks, bugs get in, you get cellulitis, you're back in the hospital for antibiotics every now and then, and it becomes just a recurrent saga. So it's best to take care of these things very early on. Next, please. There's another example of blood clots in the lung. You can see all this white stuff is a clot. And this is after the clot. You can see the outer part of the lung. There's no blood going to the outer part of this lung. See that? Both the lungs, and this is the right, that's the left. You can see the central part of the lung being light up, but the periphery is not lighting up at all. And we took a bunch of clots out, and you can see both the lungs light up fairly well. Next, please. There's another example. Oh my, that's nice. So, clots removed, flow reconstituted. This is the left, this is the right. Right, we got most of the clots from the upper and the middle chamber, middle part, I should say, of the lung, but the lower chamber we could not. Lower part of the lung, we could not get the clots out. They were probably there for a little while longer. Sometimes people have recurrent clots, meaning they may be happening every few days. Some clots are going up, and until it reaches a critical point, they don't feel any symptoms. And once there's enough clot in the lungs, oh my God, something is going on. They get short of breath, they get fatigued, they get tired, so that's when they come. So the clot's in there for too long, then obviously it gets stuck to the wall of the pulmonary artery and you can't suck them out. Next, please. Okay. So this is one of the things that has really helped large number of population. It's called amulet device placement, or some people may have heard of the Watchman device. So what is this? So this is a pouch in the left upper chamber of the heart. It's called the left atrial appendage. What happens here? This is an organ that has no function. Just like your appendix has no function, this is appendage. So I'm sure some people in this hall may have had atrial fibrillation in the past. Some have chronic atrial fibrillation, which is an irregular heart rhythm. When people get atrial fibrillation, the upper chamber of the heart doesn't contract, doesn't squeeze. It kind of quivers, but doesn't squeeze. So when it doesn't squeeze, blood stagnates in this chamber. This is a kind of downward going pouch. When it squeezes, then blood gets pushed out and goes into the lower chamber through that mitral valve that I showed you earlier. But if it just doesn't squeeze, then this becomes just like a sac, like a pass-through structure. And then the blood stagnates and a clot forms. And therefore, patients with atrial fibrillation who are high risk, and high risk is defined as age above 70, diabetes, history of heart failure, history of hypertension, previous history of stroke. So those patients have a higher risk of the blood clot forming here, breaking loose, and going out of the heart. And when they go out of the heart, what is the first organ? The brain. So the clot goes to the brain, you get a stroke. The clot goes to the eyes, blindness, can go to your arms and your hand will go dead, can go to the legs, it can go to the bowels and cause what we call mesenteric infarction or ischemia. It can go to the kidneys and mess up your kidney, it can go to the liver, it can go anywhere. So wherever that clot goes, it will cause end organ damage. And therefore, up until not too long ago, these patients were confined, I shouldn't say confined, but condemned to a life of blood thinners. And blood thinners is okay for people who are youngish, but as we get older and our gait is unsteady, we have higher fall risk, or some people have cancer and they bleed a lot from the bowels. Some people have ulcers in the stomach and they bleed from the stomach because of blood thinners. Some people fall and they bleed in the brain. Some people have stroke and they have a higher chance of bleeding. So these group of patients, which is a large group of patients, they cannot take blood thinners. If they can't take blood thinners, then clots will form, then they'll have ramifications of that, as I discussed with you earlier, ramifications in the form of stroke and other problems. So what we have done is, we put a little plug in here, it's like a filter. So even if a clot forms here, it can't come out. It's a filter. And we go from the leg up, go to the right side of the upper chamber, cross it into the left upper chamber, we deposit this filter, and we come out. Again, no surgery, no cutting. The first device that came out was called Watchman device, which is a little bit different, but does the same thing. But the newer device is called the Amulet device, which has two discs, an inner larger disc and outer thinner disc. And there are a lot of fenestrations here, as you can see. So this hooks onto this and it does not come out. Before we release this, so that's a cable, and we release the cable from this, and then this becomes a permanent part of the heart. But before we release it, we do a tuck test. And if it doesn't pull out, obviously it's going to stay there. Once we do the tuck test and it doesn't pull out, then we release it and it stays there for the rest of your life. Within 6 weeks or so, new cells will cover this disc, and this whole appendage will be totally excluded from the heart. And we don't want that appendage anyway, because it's of no use to us human beings. Now, if somebody's having bypass surgery, they nowadays just suture this up. They take a pursing suture and close it off. But if someone is not having bypass surgery, and not many people have bypass surgeries these days, then this is a very good option for them. Now, we are now doing trials where, so initially FDA, or not initially, but now FDA only approves this for patients who cannot take blood thinners, for a variety of reasons I just mentioned. But now we are doing a trial where, whether they can take blood thinners or not, we are randomizing them to with this versus blood thinners, even though they can or cannot take blood thinners. So when hopefully that result will come out probably by summer of next year. The initial results are looking very good. But why would one have to be subjected to take a strong blood thinner and then face the possible consequences of bleeding when this can be done and you don't have to take strong blood thinners and over long haul just aspirin? So that trial is in process right now. Lastly, I would like to turn my attention to something called impeller heart pump. This is a very, very nifty device. This is like a heart-lung machine. You are putting the patient on left ventricular assist. Generally, that happens during surgery, open heart surgery, but that is, you have to cut the chest and open this. This is done through the groin. So when do we do this? So there are a lot of patients who need angioplasty, stents, due to multiple blockages. They're not good candidates for open heart surgery because the heart is too weak. Again, some people may have what we call porcelain aorta, where the aorta is totally calcific, and therefore they cannot have open heart surgery, because when we cross-clamp the aorta for bypass, it breaks off some plaque on the inside of the aorta and showers a whole bunch of plaque up into the brain, and they get stroke. So those patients are not good candidates for surgery. Patients who have short lifespan due to other reasons, they kind of patients who have bad lungs, bad emphysema, COPD. Patients who come in with cardiogenic shock, wherein the blood pressure is 50, 60, 70 due to big heart attack. In the face of an ongoing heart attack and what you call cardiogenic shock, which is very, very low blood pressure, one cannot go to open heart surgery. So in these patients, we put in this device called an impeller device. It goes from the leg through the aortic valve into the left lower chamber of the heart. There's a rotary pump here. It sucks the blood. There are multiple holes here. It sucks the blood, and then it comes out. There are a few holes here. So it sucks the blood out from here, and it throws it into the aorta. So essentially, it takes over the function of the heart. So just yesterday, I did a case. There's an elderly gentleman whose heart muscle is very weak. There's something called ejection fraction. Normally it's 55 to 65%. His was 20%. His kidneys are bad. I can't give him much dye. He had a little heart attack coming in. He had stent put in about 3 years ago somewhere else. And we did a heart catheterization. 2 out of the 3 arteries were 100% choked up. And they are so small that they cannot be bypassed. Plus the heart is very weak, so he would not be able to survive open heart surgery. The third artery had 90% blockage. And that's why when he came to the hospital, he was in shock. Because there's one artery which probably some clot must have formed inside that 90% blockage and significantly compromised blood flow. Interestingly, there's one artery that has severe blockage was supplying natural bypasses to the other 2 vessels that were 100% choked up. So now this patient is living on one pipe that is severely narrowed down. So the heart is struggling, doesn't get any food, which is blood. So we put him on this impeller device. This can give anywhere from 2 different kinds. One is a little larger than this. Anywhere from 3 liters per minute to 5.5 liters per minute blood flow. Normally the heart, I'm sorry about that. Normally the heart itself gives about 5 liters per minute. So if I can get 3.5 liters with this smaller device, and if I need a bigger device, 5 liters, it's a temporary thing. It becomes very easy for the patient. Now, when I do angioplasty on that, like one I did yesterday, when I inflate the balloon in that 90%, 80% blockage, for that 30 seconds, the heart has no blood flow because those other 2 arteries are gone and this artery has severe blockage. So, under normal circumstances, that patient would just fibrillate, heart would fibrillate, and he would die. But in this situation, he won't because there's constant flow of blood. The brain is getting blood, the kidneys are getting blood, all vital organs are getting blood. And I can safely do this vessel angioplasty without any problem. There are patients whom we have done all 3 blood vessels, angioplasty instead of all 3, because this makes the patient's condition very stable for us. We get enough time to do all these procedures. Otherwise, we are hurrying because patient's blood pressure is so low and we cannot inflate the balloon long enough for effective angioplasty results. So this is one of the relatively new device that allows us to do angioplasty and stent in very, very sick patients who would otherwise actually die. Now this device goes to a 14 French sheath, which is about the size of my middle finger. The new one that will probably come out early part of next year is much smaller, a little less than my pinky. So again, as I said, constantly innovation is going on, constantly new devices are coming out, constantly new drugs are coming out for better management of patients who have cardiovascular disease. I'll turn my attention now, focus to treatment of congestive heart failure, which unfortunately the slides are not showing. But I can. So over the last so many decades, once patient had congestive heart failure with weak heart muscle, patient was condemned to a very short lifespan because there's not much we could do to improve the function of the heart. Particularly in the early stages of congestive heart failure, the heart muscle is very weak. But a whole slew of medications have come out in the last 4 to 5 years, which significantly improves morbidity and mortality and decreases significantly p-value of 0.001, which means statistically very, very significant hospital readmissions for heart failure. Because once you have heart failure, every now and then you're back in the hospital, we give intravenous Lasix, which is a diuretic, a water injection that makes you urinate a lot more, get the fluid out of your lungs. They go back home, same cycle repeats in a few weeks, few months. So back and forth, back and forth. But these newer medications not only improves the efficiency of the heart, but it may even strengthen the heart muscle. So one of the medicines is called Entresto. Some of you may have been taking it, you may be reading on, you may seeing it on TV. There are a lot of advertisements on TV. Very, very effective drug. So over the last 3 decades that I was practicing, we were using a drug called ACE inhibitor, or lisinopril, ramipril, which were good, but certainly not as effective as Entresto. I've had patients whose ejection fraction went from 25-30% to 65%. I saw a patient in the office today. Her ejection fraction was 40%. She was struggling to run. And today she said, "Doc, I feel great." I said, "Well, I know you feel good because I just did your echo last week and it showed normal heart muscle function." Another patient a week ago who I saw, Ms. Dawson, I don't mind taking her name because I told her I'm going to take her name. She couldn't even walk from here to there. She couldn't even climb half a flight of stairs. Now she's running up the stairs with this medication. So that is one of the medications that we use at a lower dose first and then gradually increase the dose as tolerated. The other drug is called SGLT2 inhibitor. These are drugs that were initially came out, were released by FDA for diabetes management. But what they saw was these patients with diabetes and heart failure, the heart failure improved because it caused the patient to urinate much better. So normally when we use the other diuretics, there is other complications. They have Lasix and spironolactone and aldactone and all those kind of things. There are many other mechanisms of this drug too that which we don't still, as yet, don't properly understand. It may cause some modulation of the heart muscle. It may cause some change in the kidney to make it work more efficiently. So we really don't know exactly what it does. But it does do one thing: it improves heart failure. So now it is a frontline medication for people who have heart failure. Before, it was only approved, both Entresto and this drug called FACA or Jardiance, only for patients with weak heart muscle who had congestive heart failure. Now it is also approved for patients with normal heart muscle function with heart failure. So those patients go into heart failure because the heart is squeezing well, but not relaxing well. So it's not able to fill up with blood, and therefore it backs up into the lungs. So it has been approved for that also. The third drug called Verquvo or vericiguat, that has also been approved, and these are all additive effects. So you put the patient on beta blockers, which is Coreg, metoprolol, some of you may be taking that. Then you add a diuretic, then you add Entresto, you add Farxiga, you add Verquvo. Each one will improve the patient's condition by 10-15%. So at the end of the day, patient's outcomes are much better. So another drug that's going to be, that they're studying right now, and the early reports are very good, is called mavacamten. That actually improves the contractile function of the heart. It works on the myofibrils, the cells that cause contractile function of the heart. So these kind of pharmacological agents, particularly when used early on, when patient comes in with heart failure, will significantly improve their long-term outlook. There are devices that we use for people who came late. They had congestive heart failure, they didn't pay attention. Now the heart muscle is so scarred that it cannot regain its function. So for that, there was only one option in the past: heart transplant. But heart transplant, they won't do above age 65 unless you're Vice President of America, where he got it, Mr. Dick Cheney got it at age 75 or something. But usually they stop at 65. And heart transplants are so far and few in between. I mean, how many, if you had to have some young person unfortunately die, and their tissue has to match with your tissue. So in a place like University of Michigan, they do about 40 heart transplants a year. At Henry Ford, they do about 30, 35 a year. In Grand Rapids, a Spectrum, they do about 20 a year. So all in all, about 100, 120 heart transplants in a big state like Michigan, right? So what do you do for these patients who came late? Drugs will help to them to a certain degree, but they came too late. The heart is scarred. So for them, they have this kind of device called HeartMate. It is that impeller device, this device that I showed you, but it's surgically implanted. And it can stay in there for at least 7 years. So it's surgically implanted, and there are 2 wires that come out from here that is attached to a battery pack that you place in a fanny pack, and you wear it around and go wherever you want to go. But once you have that, you don't need any of this medication, the diuretics, you don't need anything. You can't hear any heart sounds because the heart is not working. It's a pump that's working. So you can listen to the heart, but there's no heart sound because the heart is not squeezing. So then every 7 years, you got to change this device. And at night, you can charge the battery just like the Tesla car. Put it in the socket, the battery gets charged up. Next day, here you are. You can go and play golf if you want. Not a problem. So that device also, there are only 2 centers in Michigan that are doing that. One is Henry Ford, one is University of Michigan. But that's an option. That's an option as opposed to heart transplant. In fact, there are patients who have turned down heart transplant and have preferred to put this device because heart transplant has its own problems. You have to take medications to prevent transplant rejection. Then every few weeks, months, depending upon the clinical condition, you take biopsy of the heart muscle to make sure there's no early rejection. So it has its own issues. And the heart transplant medications can cause blockages in the new transplanted heart arteries. So 6, 7, 8 years down the road, now you're looking at angioplasty again and bypass again and things like that. So heart transplant is good for certain patients, but having said that, some people prefer this HeartMate device, which is a surgically implanted pump like this. So this idea actually came from that surgically implanted pump, HeartMate device as we call it. So I would say to all of you here, and of course thanks for coming, that if somebody says you have a heart problem, don't get despondent, don't get nervous. There are a lot of options. Keep on innovating. New things are coming down, be it angioplasty, be it stents, be it valve issues. In every segment of the heart, research is going on. Stem cell therapy is still very much in play to repair a scarred heart muscle. It's just that we need to find a way to inject the stem cell into the heart muscle and that it stays in the heart muscle. All the earlier trials that were done were injected into the heart artery, but within a few seconds, most of it will just go into the circulation further out and may not necessarily stay in the heart muscle. So whether to inject directly into the heart muscle, open the chest and inject multiple areas of the heart with stem cells so new cells grow, those are the kind of things that they are working on. They're growing kidneys in Petri dish, and hopefully that'll become a reality very soon. They're growing your arteries. So when you have bypass, you use the veins in the leg, sometimes we use arteries from the arm, but some people don't have good blood vessels. And therefore, how can we grow your own artery in a Petri dish? So that is happening. They take some tissue, roll it around a tube-like structure, and let it grow over a period of a few weeks. And after a few weeks, you have an artery. So those things are happening. I think there are a lot of good things that are happening, and the only rate-limiting factor is money, which is a problem everywhere, because all this research needs a lot of money. And over the last few years, because of COVID and other issues, inflation, etc., monies are scarce to come. But still, there are enough philanthropists and enough venture capitalists and enough private equity people who put in money into these things, because if one out of that 10 projects become successful, those guys are going to make billions, not millions. So they still take a risk, and fortunately, these things come about. A lot of medical research now happens in European countries and in Israel. Well, it's very expensive to do any trials in America, very, very expensive. So there's a device that we call an atherectomy device that shaves the inner lining of the artery, which has a lot of calcium. It's called orbital atherectomy. It's like a rotor-rooter. So they wanted to do the trials in America. This was about 7, 8 years ago. The amount of money that they set aside was about $5 million. Then I was sitting in that meeting. I said, I can get it done for $200,000. So what? Not possible. I said, I'll do it in India, but it'll not cost more than $200,000. And it'll get done within 3 months. So after a lot of talking internally, they said, okay. So me and a colleague of mine from California, we went to India. We did 50 patients. It actually didn't even cost $300,000. We were done in 35 days. Based on that trial, that study, FDA allowed us to do a trial, a safety trial here of 100 patients, and then it got approved for using in the coronary arteries. So things are, so this is just one example, how expensive it is to do things in the United States. And therefore, a lot of research goes out. So the idea is born in America, sown in America, but then it gets built somewhere else, made somewhere else. And it comes back to us, but after some other countries have already started using it. So although we are leaders in medical technology, there's absolutely no doubt about that. But then we don't get to use it first. European countries get to use it first. That's okay. At least as long as 2-3 years later it comes here, and our citizens get benefit of all these new technologies and devices. So I'll end the evening here, and I'll be happy to answer any questions. I just wanted to make this more informal and show some slides and show some pictures as to what all kind of things we are doing and what all is coming down the pike. But if you have any questions, anybody? Yes, sir.
What are the top 3 sources you use so that you keep up and stay professionals?
Well, that's a great question. So every few months, there are a lot of conferences that happen around the country, and things that are not yet approved by FDA, they do some live cases of that. They do live cases of that. So we go there, we see that, and nowadays with Zoom and all those kind of technologies, we can see it from home. I don't really have to go to California or somewhere to these conferences. You pay some amount of money, $600, and I can see it live from my home. So that is one way of doing it. The other way is, fortunately, I've been involved in research before, and I've been at institutions where we did a lot of innovative work. So we still do research work ourselves and keep abreast of new things. Our hands are deep in this kind of research. For example, there's a special kind of wire. So most of the time when people get chest pain, we look at the big arteries. We put stents in them, we do bypasses, etc. But only 10% of the blood are in the big arteries. 90% are in the microcirculation, capillaries that we can't see with naked eyes. For all these years, we never had any ability to check disease of that. There are a large number of patient population who have chest pain, their stress that's abnormal. They bring them to the cardiac cath lab. Oh, your arteries are normal. Go home. But I'm having chest pain. It's in your heart. It's in your brain. You've got some psych problems. Go and see a shrink. But actually we were doing them a disservice because they actually indeed had problems in their microcirculation, which one, we didn't know about, and two, even if we knew it, there was no way to check it. So there's this wire which we now put inside the heart artery, into the distal segment of the heart artery, and we measure some pressures. We then give some medications to dilate those capillaries and measure pressures again. And then we come up with some formulation where we know that this patient has high resistance in those small capillaries, which would mean that patient has microcirculatory problem, for which there are certain medications, at least there's one molecule that may help, It's called ranolazine or Ronaxa. More research is being done to get more molecules to help improve the capillary circulation, but we just didn't know that we could do something like this and help a lot of patients. We at Crittenton were the first in the state of Michigan to use that, and 7th in the country to use that kind of device. So we are pretty much on the cutting edge of cardiology and cardiovascular medicine. And a patient from University of Michigan went there, has severe blockage, they put a stent. 6 weeks later, goes back having chest pain. They did cath. He said, well, maybe there's some moderate blockage. We'll put another stent. They put another stent. Chest pain. Then he heard us on TV. So he came from Ann Arbor to our emergency room at Crittenton. I said, maybe you have microvascular disease. So we took him to the lab next day, put in the wire. Lo and behold, he had microvascular disease. We put him on this medication. He was on TV actually. And he sings our praises all around Ann Arbor because he's a new man. He went to the emergency room twice. He had stent, which he needed. It's not that he didn't need the stent. So, but he had macrovascular problem and microvascular problem. So the stent helped the macrocirculation, but the microcirculation was not being taken care of because they didn't have any ways of checking that. So about a third of the patients who have stents and or bypass surgery will also have microcirculatory problem. So nowadays what we also do is when we do angioplasty, particularly in high-risk patients, we check the microcirculation at the end of the procedure. And if they have that also, then they get additional medications. Now, people who are smokers, who are diabetics, they have a higher incidence of microcirculatory disease than those who are not. Unfortunately, women have a much higher incidence of microcirculation. We call it syndrome X. And many lady has been turned away from emergency rooms because they keep coming, and say, oh, you have mitral valve prolapse, oh, you're too stressed, oh, you got anxiety issues, oh, you got psych problems. And they wouldn't listen to them. But even if they listened to them, for the longest time, they didn't even know what to do. They didn't even know such a thing existed. But now we know it exists. So if somebody has chest discomfort, chest pain, tightness when exertion, they have a stress that's abnormal, they have a heart catheterization, arteries look normal or mild moderate disease that would not explain the symptoms, then it is mandatory that we check for microcirculatory disease. So again, in short, to answer your question, we have to attend all these meetings because a lot of research and a lot of these things are shown live. And then we go to some workshops that will, so if you want to do something like TAVR, you have to go to a workshop, learn, then have somebody proctor you for the first few cases and then start doing them. But we were the first to do experimental TAVR, and we were first to do the commercial TAVR, which is the aortic valve. And it has come a long way over the last little over a decade. It's come a very, very long way. I still remember my mentor, Dr. Bill O'Neill, was doing a case on a weekend, and he said, Choksi, come upstairs, I want to show you something really neat, something new. So he showed me this drawing of this TAVR valve, and that was then, and it's become a reality. Not just a reality, but it has helped hundreds and thousands of patients around the world. Hundreds of thousands of patients. And this has now, this kind of treatment is done in every nook and country, corner of the world. Be it small country, big country, Europe, Asia, it's done everywhere. Because it's such a simple thing to do. And it takes some skills, but not a whole lot of skills. If you're doing heart catheterization, angioplasty, stenting, this becomes a fairly easy thing to do. Any other questions?
I was just going down to but first of all, thank you for your time for being here.
Thank you for coming.
With advancing age, even more and more, the more practical stuff inside the art. What is your opinion on using nitric oxide supplements to clear up some of it?
So theoretically, nitric oxide does help the tone of the blood vessels. It doesn't take away the plaque, but it does improve the tone of the blood vessels. But it has not been shown that if you take those pills, that the tone changes. So whether it's absorption, whether it's dosage, we don't know that yet. but there's enough data to suggest that that does help the tone of the blood vessels. Having said that, drugs like statin drugs, which a lot of general population is afraid to take because of all the negative press that they get, but it really stabilizes plaques and it slows down the plaque progression. I had patients who had severe cardiovascular disease, 70-80%. For 7-8 years, they are the same. It hasn't gotten worse. So same thing in the heart. My own mom, we put a stent in her artery in the back of the heart back in 1998, 99. At that time, she had 50% blockage of the artery on the right side of the heart. She's passed her stress test year in, year out. So as much as the negative press on set, and yes, it does have some side effects. Some people will have muscle aches. It is extremely beneficial for the vascular health of a person who already has some plaque buildup or whose cholesterols are very high. What does it do? It's not just it lowers your cholesterol. That is just one aspect of statin drugs. It has an effect called pleiotropic effect, which means it's an anti-inflammatory effect. So anytime there's a plaque, say in the heart artery, there is inflammation. Because of inflammation, there's swelling in and around the plaque. Because of swelling, the plaque will rupture. Like a volcano, it will open up. Now the plaque is opened up, the blood is flowing across that area of the plaque rupture. Chain of events happen, clot forms. A clot completely engulfs the lumen of the artery. So now the blood can't go forward, downstream. Patient gets a heart attack. In this day and age, heart attack doesn't happen from 90-95% blockages because those patients will, majority of them will have some symptoms. They'll seek medical attention, they'll go to the doctor, they'll do stress, they'll do cardiac catheterization, they'll do stent, and they'll get better, or bypass for that matter. But it's a 20, 30, 40% blockage that has no symptoms, and stress test is not going to pick that up. Stress test will only pick up significant blockages, 70, 75, 80% or more. If that plaque opens up, patient gets heart attack. So and for that now we have a very good test called coronary CT angiogram. We do CAT scan of the heart, non-invasive. We can find out whether you got zero blockage, you got 20, 30% plaque, 80% blockage. It's all there to see. So we have ways and means of looking for the blockage, finding out before it gives you trouble. We have ways and means of stabilizing that plaque, slow down the progression of that plaque, decrease the incidence of plaque rupture, and thereby heart attack. Same thing can happen in the brain, stroke, heart attack. So statins are a very integral part of care for cardiovascular disease. If you look at the incidence of heart attack when I was training in the 80s, in a big hospital like Beaumont, we used to have about 5 to 6 big heart attacks a day. Now 5 a week is a big number. So heart attacks has drastically, the big heart attacks, what we call STEMI heart attacks. So the whole thickness of the heart muscle is involved. The incidence that has gone down significantly. The single most important factor that has decreased that are statin drugs. Now there are some patients who cannot take statin. There are alternatives like Repatha, which is an injection that you take twice a month. There's another one called inclisiran, which is twice a year. Unfortunately, insurance is not covering that. That's good, $15,000, $18,000 a year. But as time goes by, it'll cover that too. So statins are very important. Yes, sir?
Have you found that valve replacement has any effect upon AFib?
It's a very good question. It all depends upon where in the history of leaky heart valve or severe aortic stenosis we caught them. So if it is chronic, meaning patients sought medical attention somewhat late, once the aortic valve or the mitral valve got very worse, but he or she didn't come to their doctor, the left upper chamber will dilate, it'll get scarred down. In those patients, atrial fibrillation may remain. But in patients who came in very early, where the left upper chamber did not enlarge much, in those patients they can go back to regular heart rhythm. If they don't, then we have this atrial fibrillation ablation treatment, which in yesteryears, and I'll tell you what it means, In yesteryears, the success rate was about 65-70%. Fast forward about 80%, now it's about 90-95% success rate. So what they do is they go in from the blood vessel in the leg with a catheter, with a wire. That wire has the ability to find out where these chaotic impulses are coming from. They kill that area, the cell, with radio frequency heat, and you're back in regular heart rhythm. So a lot of patients benefit from atrial fibrillation ablation. And just day before, we got news that there's some newer devices that are coming out that will make that procedure much safer and shorter, because these procedures sometimes take a long time. As you may have read in the newspapers today, one of the very famous lawyers of the city had AFib ablation treatment and had a stroke after that. So it all depends upon how early in the game you sought medical attention to treat that particular problem. Well, the short answer is they can go back to regular rhythm, not always. Yes, sir.
Thank you, excellent presentation. And, two questions. One, first I'll ask about money. Like things like Medicare and all, some of these procedures you mentioned, do they normally cover those?
Medicare covers all the procedures. Insurances like Blue Cross and others who give you a hard time, but the TAVR, the mitral clip, the left atrial appendage, all those are covered by all insurances now, all insurances.
Second question. As Michigan, especially metro area here, where are we from a leadership in the country from what you're talking about so far?
I think we still are probably one of the leaders in the world, not just the country. The left atrial appendage occluder, which is at Amulet and Watchman, this was the first place in Michigan that we first started using that in a protocol basis. TAVR, mitral clip, although back in California they were the first ones to adopt that, but almost simultaneously, a few months behind them. As far as coronary angioplasty is concerned, we do per capita, we do one of the highest number of interventions in America. Impeller device, we were one of the first adopters of impeller device. And the smaller impeller device that I told you, there are only 3 centers in the country that are in the trial. One of them is in Michigan, St. John on the east side. So we are still on the cutting edge of cardiovascular medicine. Hospital like Stanford, who have huge endowment, of course they are always going to be there. Cleveland Clinic is always going to be there. But having said that, I think we are no less than anybody else. What we do in the coronary area, what we do, even at Ascension, Rochester, same thing is done at Cleveland Clinic. We are no less, no better. What they do at Cleveland Clinic, we do here in the coronary arena. We do rotor, we do laser, we do atherectomy, we do stents. Everything that they do there, we do here. There's nothing that we can't do here that somebody has to go to Cleveland Clinic for coronary disease. So, yes, we are still pretty much the leaders in the world. Michigan is still way up there. Oh yes, it's way up there. I think even early on, the use of clot-busting medications like streptokinase and TPA, we were one of the first ones in the country to do that. As I told you, balloon angioplasty, Wall Street had that article. New York Times had an article. Fast forward 2 years later, when the trials results came out, they repeated the article saying the same cowboys have good results. That's the best treatment for patients having a heart attack. So I'm not concerned about Michigan. Michigan is still doing very well. Only if the weather can get a little better, then that will be fine.
I just think on the Wall Street insurance thing, we are in good hands.
Insurance is a problem in just about every state. There's no state that is devoid of insurance headaches. None. I think they're in the business of making money, and therefore, as bad as it sounds, because our economy is built on capitalism and private companies and private enterprises, but as far as healthcare is concerned, I think a single payer is probably the best way to go. Only because there's so many insurance companies that adds so much cost to the provider, be it the doctor in the office, doctor in the hospital itself, has a whole team of people to deal with 20, 30, 40 insurance companies. And then many of these insurances don't even want to pay on time. When you send a bill, they'll reject it first. So they can keep your money for another 6 months. Then they'll pay. I mean, it's just a game that they play. But still, payments do come in, and patients do get better, and patients are taken care of. The bigger problem I see with insurance companies is the pharmaceuticals. These newer drugs, they don't pay. They don't cover. I mean, we literally have to appeal and reappeal, and then peer-to-peer phone calls, and even then sometimes they will not approve it. So I use the old drug. And then if they don't get better, I said, but I'm in America. I want the best for my patient. Data shows that this is the best medication. Why do you have to use something less? They don't care a hoot. So that's why this healthcare advantage, Medicare advantage, insurance companies, some of them they give you a hard time to the patients and to us. But that's life. Still, we are better off than other countries. In the United Kingdom, their National Health Service, NHS, has gone to the parts. Canada is no better. And there's no other big country. Germany, yes, it's good, but the population is so small. They can deal with that. Our population is huge. So how are they going to deal with that? I think we are still doing very well, I would say. Anything you do, any business you do, there are going to be hiccups and there are going to be some stresses. But at the end of the day, patients do better, we feel better. Anybody else? Thank you. Yes, sir. Sure. Yeah, so the question is, are there any parameters that we should look for early signs of heart disease? So there are certain things that we keep an eye on that can cause blockage in the heart artery. So high blood pressure, diabetes, cholesterol. So medical checkups every now and then, and get your blood work done and make sure that your cholesterol is under control, your sugar is under control, your blood pressure is under control. Now, number 2, exercise. Exercise is as important as taking medicines, as important as doing angioplasty, as important as bypass surgery. Nobody's asking people to run and jog and do power walks. Just leisurely walk, moderate walk, 45 minutes to an hour every day, 5 days a week. If the weather is bad, go to the mall and walk, or invest in some treadmill or elliptical or what have you. Worst comes to worst, come and walk at OPC. That's the best place in America. There's no such place. Or just walk in the basement of your home or go up and down the stairs 20 times. So there's no excuse not to move. You don't move, you're going to get into trouble. Not just the heart, elsewhere. Your brain function, your joints, your muscles, your spine, everything. So exercise is as important a treatment tool as our pharmacological treatment and interventional treatment. Then we look at risk factors. Father, mother, cousin, brother died at a young age of heart attack. So those patients we have to be a little bit more, watch them more closely. As far as symptoms are concerned, some patients have no symptoms. The first symptom is heart attack. These are generally the diabetic patients. Diabetes affects the nerves in the legs. You may have heard diabetic neuropathy. Some people may have heard that. Similarly, it can affect the nerves in the heart and can't send signal to the brain. But some patients will have shortness of breath on exertion, chest tightness on exertion, jaw discomfort on exertion, heaviness in the arms on exertion. All these symptoms will first start with exertion. And as the blockage worsens, it will happen with lesser exertion. As the blockage worsens, it will happen even just sitting around doing nothing. Okay? So if somebody has those kind of symptoms, they should seek medical attention. It may not be the heart, but if it's the heart, you caught it early. In women, their symptoms are a little bit different. In men, the commonest symptom is discomfort in the chest. In women, the commonest symptom is fatigue. Now, all of us get fatigued, long day, work, kitchen, kids, what have you, grandkids. So fatigue is such a common thing, but that's the most common symptom of coronary disease in women. Number 2 is shortness of breath. Number 3 is chest tightness. So one has to be aware of the needs of a lady, and one should be adapt, and they should know in their mind that she may not have chest discomfort, she may just have fatigue, let me check. So you check the hemoglobin, you check thyroid function, you check other things. If all of that is negative, get a stress test done, get a CAT scan done. Because these are things these are tools that will get you early diagnosis. Today, the best tool, particularly for low to intermediate risk patients to diagnose heart problem, is CAT scan of the heart. Now, coming from South Asia, from India, we have the highest incidence of coronary artery disease and heart attacks in the whole wide world. It happens 2 decades earlier than the Western world. So if I see an Indian patient or somebody from South Asia, India, Pakistan, Sri Lanka, Bangladesh, etc., I won't mess with stress tests at the first go. I get a CAT scan for them. Because I know the arteries are smaller, they plug up faster, and familial genetic predisposition for having heart problems. Patients may have blockage in 3 blood vessels of the heart. Stress test will be normal. It'll look normal. It is not normal, but it'll look normal. And then they will have the false sense of safety. Oh, I'm fine. But they may not be fine. So for these kind of patients, CAT scan comes in very handy. So control the risk factors. Look out for symptoms. Today you're walking 2 miles every day, no problem. 2 months down the road, walking 1.5 miles, I'm a little short of breath. My own sister-in-law, she used to do elliptical, or she does, 4 days a week. 3 days a week she teaches Indian classical dance, which is very involved. She's doing fine, no medication, no diabetes, blood pressure, nothing. Father lived to be 97, mother died at 90. Elliptical, she was getting a little short of breath towards the end of 1 hour. Maybe I'm getting old, she's 68. I said, that's not old. Did a stress test, looked normal. So she was very happy. So my brother called me from Nashville and said, this is what the doctor said. I said, get a CAT scan. She didn't want it. She said, stress is good, I'm feeling okay now. I said, get a CAT scan. She waited a month. Finally, okay, I'll go and get a CAT scan. She had 100% blockage of the artery on the right side, 80% blockage of that, what we call the widowmaker, the artery in the front of the heart. If we had not done that, in the next 6 months, her chance of dying was very high. So you have to go by symptoms, but then you have to have like a sixth sense that, why is she short of breath? She's not a smoker, she's not this, she's not that, blood pressure normal. Why is she getting a little short of breath? Get a CAT scan. So we have tools today which are so simple to use, we can get a lot of information. So use of those tools by the patients, by the physicians together, I think that will improve the chances of early diagnosis of heart disease. I think we're over time now, I guess. Just a little. I'm okay. All right. Once again, many, many thanks for coming, and I appreciate your time.